Here few question and answer we selected from Evolve, and all of the question answer about the intrapartum care. Question number 1, the nurse in a maternity unit is reviewing the client records. Which client should the nurse identify being at the most risk for developing disseminated intravascular coagulations, shortly called DIC? Select all type. Before to go and read these questions and answer, I want to ask, what is disseminated intravascular coagulations? It also known as DIC, right? Or coagulopathies. What it is? It is a medical condition where the blood clots are excessively formed in the body or in the blood vessels, and this causes the rectal bleeding or vaginal bleeding, and also it leads to the low blood pressure or easily bruising, right? So sometimes the patient who have DIC, the common presentations, bleeding from the different part of the body, blood clot formation, decreased blood pressure, or petechiae, bleeding tendency, bleeding spot, right? So they select all most risks to develop. Number 1, A, primigravida with a mild preeclampsia. Primigravida means the mother who came through the labor room for first delivery, right? Mother do not have any previous history of delivery, but mother has a preeclampsia. Preeclampsia can lead to eclampsia, do not lead to DIC. Number 2, a primigravida who delivered 10-pound infant 3 months ago. So number 2, we do not get any clue that can lead to develop DIC. Nothing abnormalities I found. My mother already delivered infant 3 months ago. Why will chance to develop DIC now? 3 hours ago. So number 2 is not answer. Number 1 is not answer. Let me read number 3. A gravida 2, right? Who has just been diagnosed with a dead fetus symptom. So mother already gave 2 birth. Unfortunately, she diagnosed with a dead fetus. So chance to develop blood clot inside the uterus, right? So there are underlying cause to formation of the clot in microcirculation, and this is the dead fetus. This is the risk factor. We choose it. Number 4, a gravida whole who is delivered 8 hours ago and has lost 500 ml of blood. Do you found any abnormalities? Mother already have a 4 childs, already delivered another baby 8 hours ago. Because of the delivery procedure, mother lost 500 ml blood. Is there any underlying cause to develop DIC? No, we do not found. Nothing abnormalities here. Number 5, a primigravida, 29 weeks gestation. So preemie, first time came to delivery, the baby and premature, 29 weeks, who was recently diagnosed with a severe eclampsia. So mild pre-eclampsia can lead to eclampsia. But if anybody is severe eclampsia, they are under the risks to develop a lot of complications. And one of them is DIC. So it is also good choice, right? Let me read the rationale, what they said. In a pregnant client, DIC is a condition in which the clotting cascade is activated, resulting in formation of clot in the microcirculations, and dead fetus syndrome is considered a risk factor for DIC. Severe preeclampsia is considered a risk factor for DIC. A mild case are not. Delivering a large newborn is not considered a risk factor for DIC. Hemorrhage is a risk factor for DIC. However, loss of 500 blood is not considered hemorrhage. Next question. So the nurse is caring for a client in a labor, which assessment findings indicate to the nurse that the client beginning the second stage of labor. Select all. So the key point is beginning the second stage of labor means ending of first stage of labor, right? So contraction are regular. This is is it indicate the beginning of second stage of labor? Or membrane have ruptured. So second stage of labor basically begin when the cervix is fully or completely dilated. This is the good choice. We categorized the true labor as a 4 stages. Stage 1 we call dilatation. Stage 2 we call birth or expulsion. Stage 3 we call placenta removal, and stage 4 is recovery stage, right? And number 4, the client begins to expel clear vaginal fluid. No, it is last stage, not beginning of the 2. Spontaneous urge to push is initiated from perinatal pressure. Yes, this is indicate the second stage of labor too. As I told you, labor has a 4 stages. Stage 1 is dilatation or dilation. So stage 1, the first true labor contraction until the complete effacement and dilatation of the cervix. In stage 1, we will check the presentation, effacement, and also we will check the station. In stage 2, we call birth and expulsion. In stage 2, complete dilatation occurs and effacement of the cervix until the birth of the baby. In stage 2, also bulging of the perineum is an expected findings. Stage 3 we call placental, means birth of the baby until expulsion of placenta. During the stage 3, inspect the placenta for 2 arteries and 1 vein. This is the question NCLEX board frequently asks. And stage 4 we call recovery stage. What does it mean? Means delivery of the placenta until mother condition has stabilized. Let me read what is their rationale. They said the second stage of labor begins when cervix is dilated completely and ends with birth of the neonate. The woman has a strong urge to push the stage 2 from perineal pressure. Next question. Question here. The nurse in the labor room is caring for a client in the active stage of first phase of labor. The nurse is assigning the fetal pattern and note a late declaration in the monitoring strip. What are the most appropriate nursing action? Before answer this question, I have to know what is declaration. Before to know what is declaration, I have to know what is declaration. If you understand the declaration, then you will understand what is declaration. And if you understand the declaration, you could answer these questions. Let me tell you something more. So to answer this question, every student must know what is declaration. Before to start declaration, I want to tell what is declaration. So an declaration is an abrupt increase in the fetus heart rate above the baseline with onset to the peak of declaration less than 30 seconds or less than 2 minutes in durations. It is a declaration. So every student must know what are the normal heart rate. And we know when you monitor the fetus, the normal fetal heart rate is 120 to 160 beats per minute. If the heartbeat is faster or rapid, we call declaration. Declaration means, declaration here decrease the heart rate, right? Decrease heart rate of the fetus from the baseline. So there are 3 types of declaration: early declaration, late declaration, and variable declaration. If the baby has an early declaration, if you count the fetal heart rate, reduce the fetal heart rate before contraction in early declaration. What are the reasons of early declaration? Head compression. If baby have it, what are the treatment? Treatment is observation. You just see, observe your patients. If baby has a late declaration, if you check the fetal heart rate reduce after contraction. The reason of late declaration, uteroplacental insufficiency. If baby have it, what are the treatment options? We make sure adequate oxygen, give mother IV fluid, and also left lateral position of the mother. Also disconnected the pitone. Be prepared for cesarean section. If baby has a variable declaration, combination of early and late declaration, and reason being cord compression compared to early head compression. If baby have a variable declaration, we request mother for left lateral position or Tendelberg position, give oxygen, and prepare for cesarean section. Every student must know each of them. So now here, declaration, monitor the strip. What are the most appropriate nursing action? Number one, admin oxygen. So question said, let declaration, right? Let declaration. Here, let declaration, give them oxygen. So admin oxygen via face mask, very one best choice. Place the mother supine, no, left lateral position. Number three, increase the rate of oxytocin intravenous infusion, no. Discontinue pitone or oxytocin. Other name of oxytocin is pitone. And number four, document the findings and continue mother fetal pattern. The first is first. Give them oxygen, save the life. What are the rationale? Late declaration are due to the uteroplacental insufficiency and occur because of decreased blood flow and oxygen to the fetus during the uterine contractions. Hypoxemia result, oxygen at 8 to 10 liter minute via face masks is necessary. Supine position is avoided because it decreases the uterine blood flow to the fetus. The client should turn into her side to displace the pressure of the gravid uterus on the inferior vena cava. And intravenous oxygen infusion is discontinued when the late declaration is noted. The oxytocin would cause further hypoxemia because of increased uteroplacental insufficiency result from stimulations of contractions by these medications. Although the nurse would document the occurrence, option 4, delay necessary treatment. Question say the nurse is performing assessment of a client who is casual for C-section, cesarean delivery at 39 weeks of gestation. Which assessment finding indicate need to contact the healthcare provider? So number one, hemoglobin is 11 gram per DL. So hemoglobin within the normal range, right? Nothing problem. Fetal heart rate 180 beat per minute. Definitely it is not normal because we know fetal heart rate should be 110 to 160, 160 beat per minute is normal. So it is abnormal. We have to notify healthcare provider, right? Because this mother need immediately cesarean section. Number three, maternal pulse rate 85 beat per minute. So maternal pulse rate is within the normal rate, nothing problem. Number four, white blood cell count 12,000 cubic millimeter. So it is also within the normal range because normal supposed to be 11 to 15 times, right? So it is normal as well. So let me read their rationale. So if I ask you, what are the most common indication of cesarean delivery? So during the examine the patient, if we see the fetal heart rate is too fast, like this, 180 first minute, or if we see labor dystocia, we go for C-section. If we see fetal malpresentation or multiple gestation or suspected fetal macrosomia, means big baby, we prepare for cesarean section. So what is their rationale? They said a normal fetal heart rate 110 to 160 beat per minute, fetal heart rate 180 beat per minute could indicate the fetal distress and would warrant immediately notifications of the healthcare provider. By full term, the normal maternal hemoglobin range should be 11 to 30 gram per DL. Because of hemoglobin causes by increase the placental volume during pregnancy. The maternal pulse rate during pregnancy increase 10 to 15 beat per minute over the pregnancy reading to facilitate increase the cardiac output, oxygen transport, and kidney filtration. White blood cell count in a normal pregnancy begin to increase in the second trimester and peak in the third trimester. So the white blood cell count within the normal range. So nothing abnormal is found here. Next question. So question here, the nurse is reviewing the record of a client in the labor room and noted that the healthcare provider has documented that the fetal presentation part is at the -1 station. The documented findings indicate that the fetal presentation part is located at what area? Click the image to indicate your answer. Before to answer this question, I want to clear something and few key terminology. So if I ask you, what is presentation? Presentation does mean the part of the fetus that is coming first. Like this picture, vertex is a presentation. Vertex will come first. Head will come first. We call vertex. What is effacement? Effacement means thinning of the cervix. So cervix thinning, it indicates labor is progressing. And now station. What is station? Station means level of the fetus head in relation to the ischial spine. So you can see this is the two hip bones, and this it is called pubis symphysis, right? And this two, it is called ischial spine. So a imaginary line, if you draw along the two ischial spine, just imagine this is the constant. The station of labor or station means the station number is one of the sign of progression of the labor. Like in that area, it would be -1, -2, -3, but in that area, it would be +1, +2, +3. So when labor begins, some women will have a baby who is firmly high in the pelvis with a station of number 2, means here number -2. Also, few women start the labor with a baby that is engaged at a 0 station, means in this level, or lower, means +1, +2. So in the case of station, lower in the pelvis means a positive number. So here I said, so negative number means above this line. Positive number means below this line. So this question asking station, this documenting indicate that the fetal presenting part located at what area? Because showing -1 station, right? It should be in this area, because in that it is plus, and this is the -1, -2, -3, right? So what is the rationale? Station is the measurement of the progress of descent, the centimeter above or below the midline from presenting part of the ischial spine. So this is the ischial spine, true line. So this is noted as a negative number above the line, means this area, and as a positive number below the line, means this area. As the -1 or -1 station, the fetal presenting part is 1 centimeter above the ischial spine. Here, this is the ischial spine, 1 centimeter above. Option 1 at the negative Yeah, number 5 station. Fetal presenting part should be 5 centimeters above the still spine, right? Option 2 is the negative number here, 2 station. Fetal presenting part 2 centimeters above the still spine. Option 4 is the positive 3. Option 4 is a positive 3, right? And the fetal presenting part is 3 centimeters below still spine.